So this was a Phase III GFM trial aiming at answering the question, do we have to initiate ESA early in low-risk MDS patients with anemia or after waiting the transfusion threshold? So we designed a prospective trial to answer this question, and there were two arms. In the early arm, the ESA was introduced when hemoglobin was between 9 and 10.5 grams per deciliter. And in the late arm, ESA was introduced when hemoglobin dropped below 9 grams per deciliter near the transfusion threshold. So therefore, we enrolled 84 patients, 43 in the arm A and 41 in the arm B. And the median delay of initiation of EPO was 0.2 months in the early arm and 16 months in the delayed arm. Both groups were well balanced in terms of age, gender, IPSSR, IPSS-M. And the primary endpoint was transfusion dependence, the delay of transfusion dependence, and finally there were no difference in the early arm versus the delayed arm for transfusion dependence. Nevertheless, the erythroid response rate was higher in the early arm, 85% versus 55%. This was clearly significant. And the duration of response was numerically longer in the longer arm, 32 months versus 20 months. Then after we evaluated the molecular IPSS-M to see whether it could predict response rate, and both groups were well balanced in terms of IPSS-M and gene mutations. But when we evaluated the ESA-IPSS-M score, which was published last year by Marco Radi and Valeria Santini, so this score integrates endogenous erythropoietin level and IPSS-M. And there is quite a complex formula to calculate that. But to be simple, when the score is high, the better the response and the longer is the delay of transfusion dependence. So in the early arm, it was striking to see that this score could predict the patients with a higher response rate and with a longer delay of transfusion dependence. So to summarize, early initiation of ESA did not delay transfusion dependence, but it leads to a higher response rate to ESA, and simple molecular and score which integrates endogenous erythropoietin level can predict a subset of patients who will benefit from this early initiation of ESA. So these are the results of our poster today, and we analyzed the transcriptomic, cytokine profile, and the site of analysis of these patients included in the EPO-Pretar trial. And the take-home message are that transcriptomic signatures showed that the responders, the early arm responders, have an increase of gene expression in the interferon gamma signature. And in the late arm, there are some signature correlated with inflammation. And these results were confirmed by cytokine profile, where early arm responders secrete interferon gamma with T cells and NK cells, and whereas in late arm non-responders, you have an inflammatory milieu with IL-6 and IL-10. So therefore, it seems that the early responders have an adaptive, favorable immune microenvironment, whereas the non-responders have inflammatory milieu which impedes ESA to lead to response.